Hello, thank you for coming and for having me here. So I work in Pollok at the moment, which is in South Glasgow, and it's through like the Deep End's Pioneer Scheme, which I don't know if you'll have probably heard of the Deep End, I think, or some of you will have. It's a kind of programme to recruit GPs into deprived areas. But last year I did a fellowship with NHS Education for Scotland in health inequalities, which involved working half-time in the homeless practice in Glasgow and half-time doing some academic activities, and this was a project that I did as part of that. So if I can... Oh, no. I should have checked this before. Oh, okay. Perfect. So the reason I was interested in this was that I was aware that migration to Scotland had increased significantly over the past 2 decades. So having previously been a country of net outward migration, kind of until the late 90s. In Glasgow, part of this increased diversity is due to the UK Home Office policy, in which quite large numbers of asylum seekers started to be housed in Glasgow from around about the turn of the century. And this was quite different. So I'd worked for quite a long time in London, and I was quite interested in this slightly different context. So all asylum seekers in Scotland are currently accommodated in Glasgow, and that amounts to about 10% of the UK's asylum population. They're not housed in other parts of Scotland, but there have been Syrian refugees placed kind of across Scotland. So that's... And we know that obviously migrants are a very heterogeneous group. It covers lots of different things. Some of them are very healthy, but we know that there are certain groups that are very vulnerable and marginalised and have complex health problems and difficult social circumstances. We're also concerned that some migrants are not able to access healthcare when they need it. So there are some differences between England and Scotland. Primary care is the same. In terms of the rules. So everyone can access primary care regardless of their immigration status. In Scotland, in secondary care, if your asylum case has been refused, you should still be able to access free care and there's no charging. That's kind of the main difference. So in Glasgow, there's something called the Asylum Health Bridging Team, which assist asylum seekers to register with GPs. They do like an assessment when they first arrive and actually register them, which is quite useful. But we don't know what happens with everyone else, and there is concern, the same concerns that there are over the country about staff in GP practices not knowing the rules and asking for proof of address and ID and things and creating barriers that way. And across the whole of the UK, there's been a call for better education of healthcare staff. Thinking about GP training, the Royal College of GPs has recognised within the curriculum the need for us to be able to manage diverse groups of patients, but it's quite a broad statement. The Scottish Government has recognised in its refugee integration strategy the importance of staff training. Also, GPs working in Deep End practices in Scotland. So just for those of you who don't know, the Deep End practices in Scotland are those that work in the 100 most deprived communities in the country. They have recognised how to meet effectively the needs of migrants as a CPD need. So something they didn't feel they necessarily had enough knowledge about. So there is some training already in Glasgow for GPs and trainees. So the university has ran like a series of sessions for GPs a few years ago, but it was like relatively small numbers and not for everyone. And GP trainees in their first or second year of their 3-year training have like a full day training on health inequalities, during which they have 1 hour, I think, on migrant health. And that happens when they're in their hospital placements. It doesn't happen when they're in their GP practices. So given the kind of lack of specific guidance on what the training should include or what, the format that it should take, we weren't really sure whether existing training was fully meeting needs. And there have been several studies across the UK of healthcare professionals in general that have shown that they would like to have more training, or they don't know the basics and need more training. But we didn't we couldn't find anything that looked in detail at GP training. So we wanted to explore this with GP trainers and trainees in Scotland, and find out what their experience has been, what the challenges have been that they've faced, and what were the kind of knowledge and characteristics that they felt that they needed to deliver effective care to migrants, and how training could perhaps be adapted or expanded to fill those gaps. So I interviewed 9 GP trainers and 5 trainees, and then did 2 focus groups with a total of 15 trainees. So there were a total of 29 participants, and these we've concentrated on the west of Scotland region because that's where Glasgow is, and that's where most of the asylum seekers are. Initially, I approached GP trainers that were thought to have quite a lot of experience in caring for migrants, but this was kind of based on the location of their practices, and we didn't really know which practices had the most. There's no kind of data on the numbers of migrants in practices. It was like an estimate, and we took advice from the Asylum Health Bridging team and kind of GP training program directors who had a bit of local knowledge. And as I started to reach data saturation, then we also approached practices in areas that we thought there were fewer migrants, just to get a bit more of a range of viewpoints. But I did find it harder to recruit people from those areas. So in the end, the interviews took place across 7 practices. 5 of them were inner city practices, and 2 were in towns outside Glasgow, so 2 different towns just outside Glasgow. 3 of them were deep end practices, and 3 were signed up, so that these 3 were all in Glasgow, were signed up to something called the Asylum Seeker Enhanced Service, which is a kind of contract whereby practices would attract additional funding if they looked after asylum seekers and refugees, if they had to have more than 70 registered on their list. And they were the only practices that had any coding data about how many asylum seekers or refugees they actually had. So then the focus groups took place in the kind of GP training, like local training areas. So they have like a monthly half-day teaching session. And so one of them was in northeast Glasgow and one of them was in Lanarkshire, but they kind of covered a range of practices within those areas. So that was quite useful as well. And then we audio recorded and transcribed the interviews, and we both sort of analysed it and discussed the themes between us. And we found 3 sort of broad themes and with lots of sub-themes, which I've tried to summarise. It's quite difficult. So the first one was about the challenges that practices face as practices in providing effective care for migrants. The second was about what GPs felt they needed to, the characteristics and knowledge that they felt they needed as individuals in order to provide effective care, and sort of whether they felt they had that or not, and then what they thought that educational bodies could perhaps do to help. So looking at the first one, I hope you can see that. Okay, maybe it's a bit small. So The first one, the first one that came up with challenges was definitely language barriers, which wasn't really a surprise. So everyone talked about interpreting services. Everyone had experience using interpreting services, although some people hardly at all. So it was kind of like a big range from like a few times a year to 5 to 6 times a week. Most people had like a strong preference for face-to-face interpreters, but were kind of concerned that they were becoming less and less available. And actually a couple of the trainees felt that telephone interpreting was better. They preferred it. And family member interpreters was a thing that came up a lot. People were finding that they were needing to do that and were quite concerned about that. Beyond that, though, people kind of drew attention to, they seemed very aware of various different things to do with language that were kind of preventing equal healthcare. So whether that's patient choice, about appointment system, with appointments and how that might be limited, opt-in letters from the hospital, self-referral things like the smoking cessation service. So it can affect things in lots of different ways. The next thing was about dealing with the diversity of expectations that patients might have, and the fact that they might struggle to navigate a new health system. So it was often lots of things to do with multiple family members turning up for the one appointment, and having to sort of explain about the role of the GP and how referral to specialists works and that kind of thing. Time was always a challenge. I mean, it's always a challenge. So 2 short appointments, but also too short amount of time having someone registered in the one practice, because people would keep getting moved around. So GPs felt that they weren't getting to know people enough and weren't even able to start looking after their chronic problems. And then trying to find a good appointment structure seemed to be a struggle. So most people were allocating 20-minute appointments for interpreter appointments rather than 10 minutes. But this practice felt that they had so many patients that needed interpreters that they felt like they couldn't afford to give everyone a 20-minute appointment. So they'd actually stopped doing that. And then linking in with other services was a big thing, and getting information from other services seemed to be a big problem. They didn't feel like they got all the information about other healthcare assessments that people might have had. And then, I don't know if so the second quote is about community links workers. I don't know if you know what a community links worker is. I think they're called different things in different parts of the country, but it's someone who's like embedded in the practice, whose specific role is to link patients in with community resources, and they're really amazing. They do lots of different things, but not all practices have them, and only at the moment only practices in Glasgow have them, so they can be really helpful. The practices that were out with Glasgow, they certainly felt that they didn't have nearly as many sort of services to refer people to or community resources to signpost them to. So then everyone certainly felt that non-clinical staff, particularly front of house staff like receptionists, were really important in providing good care. So some people had run training for their receptionists on communication skills. Others had hired bilingual receptionists. But some people felt that some of the staff needed more training. So, for example, the secretaries weren't able to make phone calls through language line. And then the other thing that was really, I found quite surprising is that most of the registration stuff was really left to the receptionists and the practice managers. So GPs didn't necessarily know what was going on with registration and what the process was. And then in this example, they were aware that this was a barrier. but I'm going to come back to that at the end. So the next kind of broad theme was about what GPs felt they needed as individuals in terms of characteristics and skills. And we talked a bit about whether really everyone needs to know about this kind of thing, because obviously some GPs don't work with migrants. But the feeling was that certainly for trainees, they're likely to move around, working out of hours, locum, and also demographics change. So a basic knowledge is required, and also knowing how to find out more. And certainly for the practices in less urban areas, the feeling was one of being really quite unprepared, and not really knowing where to look for things. So the main thing that came up about what this basic knowledge should include was about legal aspects, rights and entitlements, and a bit about the asylum process. And there's obviously lots of reasons for wanting to know about that, but but people felt they needed to know that. Very few felt that they really did know enough about that, and this is a really extreme, I don't know if you can read them properly. This is a really extreme example, and it was a situation that someone had encountered in hospital, and it was other staff in the hospital who thought that they needed to phone the police about an illegal immigrant. I don't know if that actually happened. I assume it didn't, but she was hearing this sort of chatter and was then, completely confused about, and it had never been clarified, and was quite concerned about it. The trainee was quite concerned about it, but didn't actually know where they stood with that, which was quite surprising. But again, I'm going to come back to that at the end. So the value of experience was widely recognised. So not just having direct experience with migrants, which people certainly felt they got more of if they worked in a deprived area, and that they missed out on if they worked in an affluent area. But also the trainers recognised that having general experience gave them an opportunity to deal with the unknown more easily. So they might not find it so difficult to adapt, but I mean, there's maybe two ways to look at that. In terms of the skills they felt they needed, these were kind of general GP skills, things that are quite essential to being a GP anyway, but the feeling was that you need to be able to adapt these to these quite specific situations. So communicating through an interpreter, talking about trauma was certainly something that people felt quite worried about, and managing more complex presentations. Then the type of attitudes, there were a range of attitudes that people felt, and this came up quite a lot about, just being non-judgmental, empathetic, open-minded. In terms of cultural competence, only one participant had heard of the term cultural competence, but they all kind of brought up aspects of this in terms of thinking about being adaptable, having an awareness of people's cultures, and but also maintaining individualized care, so not kind of making blanket, having blanket ideas about people. I thought that the second quote, this was a trainer who sort of felt that this was very important, but took culture as with quite a broad meaning, and as something that would include class, ethnicity, and other things perhaps, and something that would affect how we deliver care. This was particularly with asylum seekers, quite a few people brought up this feeling of being disempowered and not feeling like they were able to do enough. And often that was to do with the asylum system. So not something that they could change, not something that we can change with training. But sometimes this was a sort of a different feeling that was to do with not being able to communicate with people quite as well, not being able to get such a good rapport with people, and that was something that maybe training could address. And also perhaps just addressing that feeling when there's not anything that you can do. So some ideas came out of this about what educational bodies could do, which is kind of what we were looking for. So there are these very large trainers conferences that take place in the different regions of Scotland, and it was suggested that it would be a good topic to bring up there. So we've arranged to do that now at the next trainers conference, because it wasn't something that had been brought previously. That won't reach everyone, but I think the feeling was that it would increase awareness, which may be helpful. The trainees certainly wanted there to be face-to-face education sessions, but they felt the timing was important, and that perhaps it would be more useful to have it in smaller groups in their local areas later in their training. And having some kind of easy to access reference resource that would be up to date. So online, there are lots of online resources for migrant health, but I think a lot of them are quite are specific, or they talk about England, and I think that can confuse things a bit. Even though obviously much of it is very similar, and often people talked about there being like too many different things to look at and wanting some kind of like hub. And then some others were like, there needs to be somebody we can contact to ask about this. You know, if we have difficulty, we can't contact anybody to discuss cases, and felt quite isolated that way. In terms of increasing direct experience, trainees can do like swaps with other practices, and they can go for placements in the homeless practice, but they're really short, and they have to organise it themselves, and in amongst lots of other things that they have to organise, and I think that perhaps that could be facilitated more, or there might be a way to do that. One of the trainers sort of suggested that maybe involving patients in education. She was sort of like thinking this would be very difficult, but would be really beneficial, because she felt that it was really meeting somebody who was going through or experiencing these things that would make the biggest difference to somebody's empathy and actually perhaps change their practice. And then I mentioned at the beginning that curriculum statement, the RCGP curriculum statement. So some people had talked about maybe wanting to have something more specific, or specific things that people should know. And there's been apparently this has been discussed, and there's been some resistance to it because there's so much to learn already, and some people felt that training isn't long enough, which there's other arguments for that as well, I think. So this was obviously quite a limited study. This was quite small. I think that I think a lot of the people that agreed to be interviewed will probably be people that are more interested in this. Although we did get quite a big range of experience, so I think that was useful. And obviously it's just GP perspectives. It's not about what other people think we should know or about what patients think we should know. But there has been quite a bit of qualitative work done with patients in Glasgow, some of which I think does reflect some of what I've discussed. I think it was, but I do think it was really illuminating in terms of just the kind of range of experience that GPs have and trainees have with migrant healthcare, and how they will just sort of like adapt and learn on the job and get by, but are actually worried that they're not providing best or equal care. There's obviously a limitation to how that can be addressed with training, but there was clearly a feeling that there should be a basic awareness and a basic knowledge, and that people didn't necessarily have that. And in particular, it highlights this confusion about rights and entitlements, which has obviously been highlighted a lot all over the country. But I don't know if, I mean, it wasn't clear to me that that was, that was, you know, whether or not that was an issue in Scotland previously. One thing I just wanted to mention at the end was that so when I did these interviews, there wasn't really any very clearly written guidance about what should happen with GP registration, as there was, because I think there's something very similar that in the like NHS England guidance, and this only came out in September, so it was after I'd done the project, and it was sent around to all the practice managers. I don't know whether anything's happened with that. I asked my practice manager in Pollok, and she was like, oh yeah, we already knew that, you know, and was very clear that that is what, you know, they ask for these documents. If people don't have them, it's fine. But she was, you know, she said, oh, but there's loads of other practices that don't, you know, they just ignore it. So I don't know how true that is, but I'd be interested to know whether that's made much difference. And then I've just got some references, which it'll all be on the stuff. Thank you.